The patients that come in and they're like, oh, the hard part's over, the surgery's over. There's going to be a lot of rehab that's arguably the harder part for the patient. I think that those patients tend to struggle a little bit because they have it in their head that it's already over.
My important role in the whole operation is that 90 minutes that we're in surgery, but it's the physical therapists who probably make the biggest difference.
Yeah. I think trying to do it on your own is a good idea, like your heart's in the right place. But again, this is what we're trained to do, and this is what we're really good at. And we say that we're movement specialists.
I found myself using a cane for much longer than I anticipated, but I needed it as a training tool. I mean, it's such a profound change in your gait. You don't want to train or make a bad habit out of a bad gait. Welcome back. Today we have a special guest, Caroline McCoy, a physical therapist with a PhD in physical therapy, for an expert discussion. Many people ask me about PT, and while surgeons understand much of it, PTs have an expertise that we lack. I even consult with them myself, often for gait analysis, diagnostic insights, and recommendations for further treatment. A common mistake is equating personal trainers with physical therapists. While not to belittle trainers, the gap in education and understanding, especially concerning pathology like arthritic and diseased joints, is vast. For treating pain or problem joints, consulting a physical therapist is essential. They may work with your trainer, but remember there's an educational difference there. I'll get out of the way. I hope you enjoy my conversation with Caroline McCoy. So I want to introduce you to someone who is a very valuable member of our team. This is Caroline McCoy, a physical therapist that works here at Texas Orthopedics. Caroline has a doctorate in physical therapy. I wanted her to come on and tell her side of the story, tell what the life of a physical therapist is, what she sees from a day-to-day standpoint that could help patients, particularly when they're recovering from hip and knee replacement surgery. Caroline, thanks for joining us today.
Thank you for having me.
A lot of people don't even understand what a physical therapist is. They confuse it frequently with their trainer, and they don't understand the value of it. But you actually have a PhD. You're a doctor. I know you're careful not to use that term in the medical setting just because it can cause confusion. But tell us about the training and background of a physical therapist.
Yeah, I do think there's a lot of misunderstandings around this. So we do have doctorate degrees, but we're doctors of physical therapy. So we have a 4-year undergrad degree, typically in exercise science or kinesiology, something that's movement-based. And then we have a 3-year grad program after that. That's the Doctor of Physical Therapy. And then our clinical rotations are built into that program as well. So when we finish school, we have a DPT degree, which is a Doctorate of Physical Therapy degree. And then we take a licensing exam. So then you're licensed in your state to practice physical therapy.
When we see patients in the office, a lot of times there's some resistance to going to physical therapy. They think, well, I can do this at home. I can go to the gym. I can look up these exercises on YouTube or the internet. Can tell me about what the advantage of coming into the office, working in a gym setting with you all.
Yeah, I think trying to do it on your own is a good idea, like your heart's in the right place. But again, this is what we're trained to do, and this is what we're really good at. And we say that we're movement specialists. So it's our job to find the deficits, find kind of where your pain is coming from or why the pain is there, maybe where there's weakness or range of motion deficits, and then to help you work through that. So it should be individualized and tailored to you, whereas a sheet of exercises from the internet might not necessarily be super specific to what you need to work on. And that's the benefit of coming to a PT is they're going to meet you where you're at, so you can then work through what you specifically need to work on.
I find myself convincing patients or trying to convince patients all the time that you really would benefit by going to see a physical therapist. And I explain to them that, look, physical therapists know a lot of things I don't know. They have an understanding. I will consult with them for my own needs sometimes. Say, hey, what do I need to work on? Or do you see something abnormal in my gait, et cetera. The other thing I think that is valuable about physical therapy is that sort of longitudinal continuity you get with patients. You get to spend, typically 45 minutes to an hour with them in action, so to speak, to detect subtle differences and where they may be tight, strong, weak, what they need to work on. So I oftentimes lean on therapists to help me diagnostically.
Yeah, and I think that's one of the huge benefits of PT. Just the way our healthcare system is, you do get a lot more time with your PT than you typically get with your orthopedic surgeon or just your practitioner as a whole. So we get to find out a lot more information. We get a lot more time to ask those follow-up questions when the pain comes. What makes it better? What makes it worse? So sometimes we get a lot more information, and then, we get to see it happening. So you have pain going downstairs, practice this, let me see it, so then we can help with the diagnosis side of it.
I think there's also a misunderstanding that we are micromanaging or directing the physical therapy. And the truth is, probably 90% of the scripts I write are eval and treat. I want your evaluation. I want your expertise so that you can work on the physical therapy side of things. Now, I do think there's a role for surgeons to, for example, put guardrails or weight-bearing restrictions, or if hip precautions are in place, because we have the advantage of knowing the x-rays and the MRI scans and knowing what happened in surgery. So there is a role for that. But by and large, people ask me, well, what are they going to do? And I said, I don't know. They need to assess you and then tell you what you need to work on.
Yeah, and I think that's the way that it should be, is that we work together as a team. So obviously the orthopedic surgeon or the doctor is going to bring their side of it as like, this is what you need to focus on or maybe avoid for this time period. But then we get to fill in the gaps on the other side of it to figure out what specific deficits need to be improved on or worked on. But yes, when it's done correctly, we're not against each other. We're on the same page for the betterment of the patient.
This channel focuses on hip and knee replacement surgery predominantly, but orthopedics in general to some degree. I'd like to talk a little bit about knee replacement recovery. Number one, because I went through it myself. But number two, that rehab is probably even more mission critical than it is with a hip. Not to say it's not important with a hip, but can you tell me about some of the common mistakes you see people make in knee replacement recovery as far as their rehab goes?
Yeah, I'm very lucky, at least where I work, where the surgeons do a great job of pushing the PT side of things after surgery. So typically that's not a huge barrier. Most of the time my patients come to me and they relatively understand what the PT side is going to look like, whether they had home health first or if they came straight to outpatient ortho. But there are certain mistakes that patients make, maybe not being consistent with their exercises. That's a very common one. They're like, well, there's discomfort. I don't want to do them. There's going to be some discomfort along with it, but there's that light at the end of the tunnel after the surgery where things are going to get better, but you might have to push through a little bit of discomfort in the short term. I see patients often discharge their walker or their cane a little bit too early when they're still limping, and I do think that can be a mistake. So that's something that I wish people kind of waited for a little bit more guidance with their PT or their healthcare team as a whole, into when the best time to discharge that is.
I couldn't agree with that more. I found myself using a cane for much longer than I anticipated, but I needed it as a training tool. I mean, it's such a profound change in your gait. You don't want to train or make a bad habit out of a bad gait.
Agreed.
So I think that's a really important point. Are there certain personality characteristics or things you see in people that say this kind of person tends to do better than another? I mean, do you have some sense of who you can predict who's going to fly through therapy and who's going to struggle?
I think there are general guidelines, but we know that everyone is just very different. So sometimes even the patients that I think are going to do really well, I'm wrong. And sometimes the other way around. But I think having set expectations, or I should say realistic expectations, does go a really long way. So patients that understand kind of what's ahead of them, the patients that come in and they're like, oh, the hard part's over, the surgery's over. There's going to be a lot of rehab that's arguably the harder part for the patient. I think that those patients tend to struggle a little bit because they have it in their head that it's already over, when is really the hard work's just getting started. But I think the patients that are ready to do their exercises, they're ready to listen to their PT and listen to their doctor, those are the patients that tend to do the best because they're just ready to learn, ready to do whatever's necessary. And then they go back to that, like, I know this is going to get better eventually. And they have like a realistic timeline as to when that's going to be. Those patients tend to do well.
And are there any sort of concerning signs, milestones, et cetera, that you look for at a certain time frame in recovery and say, you know what, we might need to talk to your surgeon?
I think there are general timeframes and range of motion expectations. But again, everyone is very different, and where they started is going to affect that. So patients that really struggled with range of motion before surgery, they're probably going to be a little bit slower to regain motion after surgery. And so that's where it's helpful to know. Patients that do prehab, for example, because they have a realistic expectation of PT and what's going to happen, those patients tend to do well. A lot of our surgeons go with that 2-week mark being at about 90 degrees tends to be realistic and an attainable goal. And then that 120 is typically for flexion is typically our end goal. I think those are very helpful just so patients can kind of see where they are compared to general population. But I wouldn't say that that's the end all be all. Like if you're not at 90 degrees by 2 weeks, that's a big deal necessarily. But it can be if we're not at 90 by maybe the month mark or something like that.
And frequently with home health involved, you're not getting patients until they're, 2 or 3 weeks down the road?
Correct. I typically, at my practice, the surgeons have the patients do home health for 2 weeks, and then they transition to outpatient ortho after that. So by the time they get to me, I like them to be at about 90 degrees, but I also know they're just now starting with me. So if it takes another week or two for us to get to 90, I think that that's okay, as long as we catch up relatively quickly.
How do you deal with someone who comes in and they're just discouraged? They say, the pain is too much. I'm not meeting my range of motion goals. How do you handle that?
It can be difficult, and it's obviously very patient dependent. So some patients do really well knowing the numbers, setting goals, like, hey, we're going to get through this. Let's try to get to 90 degrees by next week. Some patients, that is a really helpful motivator. Some patients, it's not. And so maybe I'll take the measurements, but I don't tell them because it's not necessarily going to help if they're already kind of just frustrated with the whole number process. So a lot of it is just kind of knowing the patient, which again goes back to a positive because I get to spend so much time with them. But the more that I can chat with them and get to know what motivates them, sometimes checking back in on the first day when I asked them what their goals were, we kind of revisit that. Something that I tell my patients to do a lot is you need to zoom out and kind of look at all the progress that you've made so far. So when you're in the thick of it day to day, it's hard to notice the progress. But when you zoom out and you compare yourself today based on the day after surgery, we're doing a million times better, right? Maybe we've gone down from the walker to the cane and you're back doing your activities around the home daily. And that can be a little bit of a motivation of just like, oh, that's right. In the past however many weeks, I've made this much progress. So if that continues, I'll continue to get better. But I think a lot of it can be mindset based. So just trying to get the patient to focus on the good rather than the things that they still need to improve on, that can help a lot.
One of the biggest innovations in my career has been what we call prehab, physical therapy before surgery. And we realize how critical that is. Probably first and foremost is for fall prevention, because falls is maybe the single biggest early complication that we deal with. And one of the other reasons I think prehab's helpful is we kind of get an idea of who can really do this and who's going to be committed to it. Can you talk about some of the things that you all work on in prehab? And we in the office have just very rudimentary assessments. I've talked about in another video of mine. I do what's called the no-hand stand test.
Mm-hmm.
And to me, that kind of demonstrates gross readiness for surgery and their relative resistance to falls.
Yeah, I think having patients come in before surgery can be extremely helpful, not just from physical readiness, so range of motion and strength and fall prevention, but also when we go back to mental and expectations and realistic timelines, having that patient understand exactly what things are going to look like, especially for a more high anxiety patient, I think that can be a huge game changer for them. But we do have them practice a lot on just, hey, if you're going to work with the walker for the first couple weeks, this is what that's going to look like. When you transition to the cane, maybe they've never used a cane before, this is what that's going to look like. So they can go ahead and practice those patterns because just like you said, after surgery, you're in pain, you don't have a good sense of feeling in that leg because of the weakness. Things are much harder. So having them be a little bit less strange, it's something that you've tried before, that tends to be very helpful. But then going back, we're trying to get you as strong as possible. So that way that strength ideally comes back a little bit faster.
So people have already heard from me on how I got ready for my surgery, how I did some of the recovery on my own. I did require a physical therapist after my surgery, particularly on the extension side of things. But I think they need to hear from an expert. Let's start with the prehab side of it. What would be some things you would recommend people do on their own in preparation for a knee replacement?
Yeah, a lot of what you have already touched on, I do think is a really good place to start. So knowing where your deficits lie in your range of motion and then starting there trying to get a little bit of the range of motion before the surgery, I think is extremely beneficial, and it gets you more accustomed to those exercises. So then after surgery, you know them very well and they're very easy to do. And then I think gaining strength as much as possible. So doing the harder exercises like maybe sitting down and standing up like a squat, stair training, that type of stuff to just get your strength up as much as possible. And then the bike, I think, is always helpful in terms of range of motion and in terms of just your capacity for doing that. I think that those can get you very far.
And are you a little more aggressive with someone who's in prehab state versus someone who's maybe just trying to improve an arthritic knee? I mean, I use the rental car analogy all the time. We're a little less concerned about causing pain or damaging the joint because we need to get you ready. You're about to trade this thing in anyway. Can you talk about that a little bit?
Yes, I agree. I definitely am a little bit more aggressive if they're going to have a knee replacement anyway. But at the same time, I want them to get used to the idea that we're not necessarily just going to blow past those pain markers. It's okay to listen to the pain and make sure that it's something that you can push through versus if we just kind of like, okay, cool, pain, I'm going to always ignore that. That can end up actually causing us more issues after surgery. So I do think that's where just talking through it comes into play. So I will ask a lot of follow-up questions like, is it soreness or is it pain? Is it muscle fatigue or is it pain? Just trying to make sure that we do know the difference because that always is a hard part of surgery or recovery is knowing the different types of discomfort. But I would say, yes, I'm okay with a little bit more discomfort if they're going to have the surgery anyway, because then we don't have to worry about too much of damage side of things.
So when we did our video on some of the exercises that I like to use, and it was interesting. You gave me some feedback, like I don't really like that one very much. So I want to hear from an expert. Recovery wise, let's focus on range of motion here initially, which is what most people struggle the most with. How do you recommend people work on their flexion? How do you recommend people work on their extension? Again, flexion is bending, extension is straightening.
Yeah. So for flexion for the bending, my favorite one is heel slides. So where your foot is on something and you're using the strap. I say a belt or a dog leash to kind of pull you a little bit further. That tends to be my favorite one. The one you're sitting in a chair and you're leaning forward, I don't dislike that one necessarily. But once you've gotten a little bit past 90, I think it's hard to really get much more out of that one. So those tend to be the ones that I tell patients to do the most. And after surgery, I have them do it pretty consistently. I would say 3 to 5 times a day, depending on the deficits and what we need to work on. In terms of extension, so the straightening out, my favorite will always be where your ankle is propped up on something and then knee is kind of pushing down. So you're letting gravity push you down. I like that one because it can be relatively passive. So the patient can just be sitting in that position, not really thinking about it or doing anything. Or they could double whammy with an ice pack on it. So it's kind of pushing them down a little bit further. The one where you're laying on your stomach and your legs are hanging off tends to not be one of my absolute favorites just because there has been some research to show that hamstring activation increases with that one. So your hamstrings are kind of guarding the motion more so. And I do think, especially if someone is really fresh post-op, that's not really a comfortable position to get in. Or if they're already really nervous, then they just kind of bend their knee and hang out there and they don't really let their leg relax in the way that it should relax for that exact exercise.
How long do you think postoperative rehabilitation should go on for? I mean, it's sort of dogma, really just sort of tradecraft that we kind of say 3 months of physical therapy, but probably it's really different for everyone. I tell people that I think you're sort of malleable in that first 3 months. So even if you hit all these goals at 6 weeks, I worry if you quit therapy, you can slide backwards. And I can tell you from having my own knee replaced that I found even 5 or 6 months later that if I got a little lazy with it, that I would lose some of that motion that I worked so hard to get. Any idea of how long do you think it needs to be customized? Should we have sort of prescriptive amount of time people need PT after knee replacement?
I agree. It can be very, very specific based on the patient. I think some patients are the rock stars that are going to be consistent with their exercises and they can be done with PT a little early. And then on the other side of it, we have the patients that just really struggle with confidence in doing it independently. They want to continue with a little bit of guidance from their PT and they tend to stick around a little bit longer. I think 3 months is a realistic time frame, and it's something that I tell my patients is just, I think it's good to go ahead and get it in your head that you're going to be in here for about 3 months. And that's not always at a twice a week, every week. We kind of start to, I say, wean out of PT. I want you to kind of slowly spend more time outside of the clinic and without me. So that way we can work on, again, your confidence with your exercises, your ability to work on things without the guidance from me telling you what to do and what not to do. And during that time, you're always increasing your activity levels independently. So I think the 3 months is a good kind of starting spot, but it's very different depending. And that's a good thing about PT is that's where we get to come in and make our own judgment. And then ideally, we're on the same page with the physician in that we agree what's best for the patient and however long that might be. And for some patients, it might be closer to the 5-month mark. Some patients, it might be closer to the 2-month mark, but it's more so dependent on you, your goals, what you need to get back to. So if you're someone who wants to get back to more active things that you're really struggling with, you might be in here a little bit longer. So that way we can get you back to all the things you need to get back to.
Along those lines, what are your thoughts on some of the sort of telehealth physical therapy apps now? And some people are even trying to move more towards a independent, self-directed physical therapy program. I still have yet to embrace that just because I think this is so difficult. And we know so many people, even in a supervised setting, simply fail with their physical therapy. Do you have thoughts on how that's moving? It's certainly, there's costs involved, et cetera, that
Yeah, I haven't, to be honest, I haven't had a ton of experience with it, but from what I've heard and what I have seen, I do think there's a benefit to having hands on people. And I think especially physicians can probably understand that yes, I can guess that your leg is weak based on how you're walking and how you're moving, but it's going to benefit me a lot to test that muscle and kind of push into my hand so I can really see the quality of the movement and assess the strength hands on. And same thing when it comes to treatment is yes, there are certain things that like your home exercise program that you can do independently. You don't really need me there for it. But I don't think that's true for absolutely everything, especially something like a total knee where you're going to get to a point with range of motion where we're going to have to be a little bit more aggressive and you're going to have a little bit more hands-on treatment with your PT. So I understand the idea of it, and I understand sometimes people think it's a hassle to come into PT. Maybe it's out of their way, maybe it interferes with their work schedule. But I think at the end of the day, sometimes sacrifices have to be made in order to get you better so you don't need to do PT for forever. And that's what I tell my patients is I don't want you to need me. In the end of this, I want you to be super independent and you feel really confident that you can do all this without me. And I think one of my hesitancies with some of the more like app-based or online-based PT is that you're missing a key factor that might come up later if you don't get to address it in the short term.
what about the patient that says, well, I have that equipment at home? I mean, can you talk about what a physical therapy gym typically provides from an equipment standpoint that people just are not realistically going to have access to?
Yeah, I think agreed. There are certain things that you can do at home, and that's awesome and that's great. And I do want you to do those. And we'll get to a point where we add that into your exercises at home. But I mean, I would say the biggest thing that the PT clinic has that you don't is the PT itself. So the therapist that's there to help adjust movements if you're doing them incorrectly or if can make the modifications. So I think if an exercise is way too easy or way too hard, that's where we come in to make a modification so that it's doable or challenging. And that's something that a lot of patients don't necessarily know how to do on their own. So they'll be like, oh, hey, I did those exercises and they hurt really bad. That wasn't necessarily the goal. I would have loved to have been able to sit there and modify it with you so that way we could have found a more doable way of doing things. We also have equipment so we can do like gravity eliminated squats. So there's a little bit less gravity on you and you can focus more on the movement pattern itself. So then as your strength builds up, we can do real squats. So sitting down and standing up without pain. We have a lot of things like that. And then a lot of modifiable like weights and bands. So maybe it's not quite to you're not at a point yet where you're strong enough to do a heavier weight. We can start with the lighter ones and kind of work your way up until you're at one that you may have at home.
What would you say is the number one barrier to people participating in PT, being able to come in and do it regularly?
I feel like it's more so mindset and opinion. So I think a lot of patients just decide or think that they don't need PT without ever actually going to PT. So I tell patients a lot, even if you just come to one visit and you guys get to chit chat through the goals and what to work on, I think that by itself can be a huge benefit. I do think sometimes people have work, but most PT practices open early and then they close late in order to try to get people before work and after work. My clinic, we open at 7 a.m. and we close at 6 p.m. So we can try to get you either before you go in, maybe on your lunch break, maybe after. So I think if you're working with the right people, that really shouldn't be an issue that you can't get there in the times that they're open. I think it's more so your readiness or your ability to just go to PT and kind of see what they can do for you.
Do you ever run into any financial barriers? I know sometimes I hear from patients that some of the private insurance, they have extremely high copays. I mean, they're almost paying for a lion's share of the visit out of their own pocket. And then also we hear Medicare putting a number of visits that they're restricted to per year. How often do you run into those problems?
It does happen. It is just an unfortunate part of healthcare. I think a lot of that can also be dealt with by just chatting with your therapist. So I've had patients that have had really high copays. Maybe it's not realistic for them to come to PT twice a week, but we work with, okay, maybe you come every 2 weeks and we update your exercises every 2 weeks. So that way you can do these things independently. Then we get to do a check-in. Then you do these things independently. So there are some loopholes, or more so just the conversation of, if we kind of really zoom out on this, if we hit it hard right in the beginning and we make sure we're super consistent, so then ideally maybe you can discharge a little bit earlier, we really would be saving a little bit of cost rather than kind of continually dragging it out for months and months. And then, yes, Medicare does have a cap, and certain insurances have a cap as well. Maybe they give you 20 visits or 30 visits for the year. And that's something you chat with your therapist about so that we can ideally work around it. My goal is never to just blow through visits just for the sake of blowing through them. But I also don't want to leave the patient in a position where they're going to need more PT. And it's kind of, we can't do it because you already used all of them. So it can be hard to work through that, but that's something luckily your therapist is aware of when we review with your insurance kind of the copay and the amount and how many visits you get. So we are aware of it on the front end. It's just something you guys have to chat about to try to prevent that from becoming a barrier.
So we do have to talk a little bit about personal trainers. Don't want to belittle them in any way at all, but I think it's important to understand people, they usually have a relationship maybe with that person for a long period of time. They're knowledgeable, they know a lot, and there's a lot of trust factor there. But I think people should understand, maybe you can talk about this, that generally physical therapists, they're willing to work with your personal trainers. They're willing to help you out there and kind of give them some guidelines on what they should be doing, what they shouldn't be doing.
Yeah, I agree completely. I think in an ideal world, they're a part of the healthcare team as well. So maybe my patient is in physical therapy for a couple weeks, and then me and the personal trainer have a phone call or a chat on the side of things of like, hey, this is what we've been working on and this is what we've made progress with. And then this is where I need your help to kind of fill in the gaps. I think a personal trainer can be a great and a valuable resource in all of this, especially going back to if there is a cap on PT or if there is maybe a barrier to you getting in, then awesome. A personal trainer can help with that. I don't see it this way, and I don't think many PTs see it this way. We're not competition to each other. It's more so that we all work together as a team for the best of the patient. It's similar to athletic trainers with our younger patients that are in high school or maybe college. We work as a team. So I'll talk to the trainer or the personal trainer of, hey, this is what we need you to work on with the patient, or hey, we're going to avoid this for this time period, and then just give the why. So then the personal trainer is like, oh, perfect. That makes perfect sense. I get why we're doing that. Thank you for the heads up or whatever the case may be. And then even sometimes I'll show them or send them a quick like, hey, these are the exercises we're working on in PT. If you guys could work on maybe not the exact same thing, but just of a similar ilk, most of the time the personal trainer can kind of take that and run with it.
What does the future of physical therapy look like? We can't go through this conversation without at least mentioning the elephant in the corner of the room, and that's artificial intelligence. Do you see it affecting the future of physical therapists? And what do you say to someone who's young and maybe wanting to go into physical therapy?
I think with the future of PT, hopefully, or in a perfect world, the AI side of things will more so just help the PTs with the back end of it. So the documentation part of it, the insurance part of it. As I've kind of stated, I do think there's a hands-on part of PT that I don't really see going anywhere. I don't see that kind of taking over by anything, which is something I'm very lucky for. When I see someone that's potentially thinking about going into PT, or maybe they're still in high school and it's just one of the options, I tell them go shadow in a PT clinic and see if that's what you can see yourself doing. There are a lot of different settings that PTs can work in. So I work in outpatient orthopedics. There's PTs in hospitals and rehab facilities. There are PTs that go to your house, pediatrics. There are a ton of options out there. And I think if you go and shadow in that field and you see if it's something that you actually like, that's going to make it a lot easier when it comes to the schooling part of it, when you already know in your head that this is the right thing for you.
So on this channel, we're real careful about asking people to spend their own money for things. But is there as I've mentioned, I did a video on this on things that I kind of a little kit that I use to help in my recovery. Are there any essentials you think people really need to have that they need to buy in anticipation of their operation?
Not necessarily. I do think it's very patient dependent. So there are things like we have a strap that we use in clinic that has like little loops for you to hold on to for like your heel slides or maybe for a stretch. But I tell patients that you could probably use a belt or a dog leash for the same movement. I think some of it is just seeing what you have at home. And then if you realize there's a void and you need to go buy something, then kind of being open to that. Same thing, most of the time patients are supplied a walker, but sometimes they end up needing to transition to a cane. So then they do need a cane. But we don't necessarily know that until we get to it. So I more so just tell patients, let's see what we have.
Any specific suggestions on walkers, like what type, and canes, what type, how they should fit, et cetera?
Again, I think it's very patient dependent. For the walker, the ones that have two prongs on the front and two wheels on the back tends to be the most stable, the most helpful. And then when it comes to canes, you want it to be comfortable. There are the ones with 4 prongs at the bottom and then 1 prong at the bottom. It's more so dependent on what you need to work on. So the 4 prongs tends to be really stable. If someone's really struggling with maybe almost falling or they're just unstable on their feet, the 4 prong might be more helpful. And then bringing it in with your PT once you have it to make sure that it is fitted correctly tends to be the best way to go about it.
What's the biggest mistake you see in how people use their walker and how people use their cane?
I think with the walker, patients either have it lowered way too far down or they hold it way out in front of them, causing them to flex forward, and then they're complaining of back pain, which makes sense. And I think that, again, is an easy thing to fix. You just need to practice with it. And then honestly, the similar thing with the cane or patients holding it in the wrong hand when they use it with a cane. So remember, it's the opposite of the affected leg.
And I always tell people when it should hit the ground is that foot hits the ground.
Exactly.
So yeah, I find it almost comical sometimes. People are sort of pushing the walker around like a shopping cart. That kind of defeats the purpose. The other sort of common blind spot I see with people all the time is if we say, well, we need to protect weight bearing or even go non-weight bearing, they don't think they can do that with a walker. They think that's unique to crutches. And that's just simply not true, which was one of what I found through my own recovery is it does help to have some upper body strength. And in the prehab, I think that's pretty important. I tell people that I had bruising on my hands from pushing around on that walker. And I was glad I had upper body strength. I was glad I had taken some weight off going into the operation. Are there any tips you can give people who may be prone to falls that could help them? Is there something they could do ahead of time, some balance exercises that you think could be helpful to them?
I think just getting as strong as possible can really affect the potential for falls because you'll have a little bit more strength reaction-wise, so being able to catch yourself. I think the other big part of it is setting up your home, which I think you've touched on this, but setting up your home to hopefully avoid a potential fall. That can go a long way too. I think practicing balance is a good idea, but doing it safely is the really important part. So yes, maybe you're practicing standing with one leg in front of the other leg, but you're obviously doing it with support surface near you. So if you do lose your balance, you can recover safely. And it's not like you did it in the middle of the living room where it was like, oh, well, darn, I'm just going to fall. But even with that, I think the safety has to be number one. And that's what I tell patients too when it comes to potentially falling or when it comes to moving on from the walker is, yes, I do want you to push yourself a little bit, but that's always going to be secondary to safety. Safety has to be the number one priority. So if you are unstable with the walker, we're definitely not going to decrease down to the cane until you're safe and ready.
Well, Caroline, I want to thank you for joining us. I tell patients all the time, my important role in the whole operation is that 90 minutes that we're in surgery, but it's the physical therapists who probably make the biggest difference. You're spending hours with those patients, and that's where the real work gets done. And As a surgeon, we can't thank you enough for what you do. I can't emphasize how important it is in the whole recovery process. So thanks for joining us.
Thank you so much. And thanks for all your support.